tissue are appropriate to return to the original shapes. We call it viscoelastic natures. Based on biphase and viscoelastic natures, we have to consider the tissue thickness, compressibility, and proper variabilities when we use the stables. Tissue thickness vary widely throughout the body from organ by organ, and the thickness of the lung organ is different from that of stomach, even in the colon and the rectum. Sometimes tissue properties are also different based on the type of the stage of the disease. For example, when the bowel has the bowel obstruction, the bowel will become so swelling and edema. And sometimes if the patient have the malnutrition or infection, the bowel will maybe change the thickness. Even within each organs, tissue thickness range greatly at various location by locations. For example, the lung. In the lung, we can see the red region is the thinnest part, and the blue region is the thinnest ones. And the stomach have a very small thickness, as we know. From the laser curve to the great curve, we go from the thinner to the thinner tissues. So, according to the tissue dynamic, surgeons should consider the state of tissue before stepping, and we can choose suitable ones. The illustration shows stable line varies on stable height and tissue thickness, and the different stable size have different color cartridge. I also call them color code. Mismatched tissue thickness and close stable height may cause bleeding and leakage. So operators should be careful to select appropriate stable height for each tissue. So when you close your stable on the tissue, if you feel it's too thick, you have better to reconsider the stable height you have decided. Okay. Everybody knows the height of the closed stable height, just between the upper and the bottom jaws in the current market, is around 2.3 millimeters. But tissue thickness, our tissue thickness is normally more than 2.3 millimeters. So how can we get the tissue at a properly closed stable height? I think the answer is compressions. The application of pressure to living tissue can achieve an adequate thickness for stapling. Compression can migrate fluid from tissues, which help to ensure a more consistent thickness in the target tissues. And after compression, tissue is ready to accommodate a secure closed staple. Okay, we know compression is very important, but how long? In these videos, we know at the initial pressure, tissue is still not completely compressed. But as time goes by, around 15 seconds, the compression may migrate fluid from tissues and to ensure a more consistent thickness in the tissues. So as compression, tissue is ready for a secure staple. And in this graphic, we can find that external force applied for 15 seconds. We can see a 0.5 millimeters more tissue compressed. In ESCOM study have found that the tissue thickness changed during 15 seconds right after immediate force are applied. So as you see in the graphic, tissue thickness changed until 15 seconds. Maybe we can think about the teeny amount. Because we consider, I just mentioned, the highest stable gap is 2.3 millimeter. And the 0.5 millimeter is a large number. If we can wait 15 seconds after the jaw close, we can compress tissue by more than 0.5 millimeter additional. We know different companies have different design for staple and the instrument mechanism. There are two different technologies which are both compressed and can tube compressed. In the right side is the ESCOM company, and the left side is the Covidien companies. They have different different type of compressions. In the Covidien design, the upper and the bottom jaws approximated. It's like an I-beam compression, which is strongly compression in the proximal. And then after we fire, compression peak will extend from proximal to the distal during your fire. But in the ESCOM design, it's called can-tube compressions. The bottom jaw moves backward and the upper jaw pushed down to the bottom jaws. It keeps similar compression stress from the proximal to the distal side at the time of the jaw close. So it's different. As we see in the Echelon design, they have systemic wide compression with 3-point gap controls. So we can get a securely stable formation line. So when you use the ESCOM staple, we suggest compression 15 seconds before fire and then fired at a normal speed. It's a Echelon video. But in the Covidien designs, the keyword of tissue compression comes from the design of their spatial knife blade. As the knife blade goes forward, it will pull the upper and the bottom jaw to make external stress compressions. So when you use the Covidien staples, you have to wait for seconds after compress and fire staple slowly around 50 seconds. Then the study point out that the can compression staple has stronger high peak compression pressure, and the IB stable compressed peak pressure during firing. It's different from the Covidien and the ESCOM design. So it's helpful. You have ever said, if I ask my customer what they wanted, they said they want a faster hose. And the same question to the patient and the surgeon, I think, is we want a safe and a secure staples. So for a safe and a secure staple, tissue hemostasis and perfusion should all be considered. And on compression, we can get better hemostasis function, may result poor tissue perfusion and possible cause tissue ischemia. But if under compression, we can get great tissue perfusion but no hemostasis. It may lead post-op bleeding or even leakage. So it's very important to achieve the right balance of hemostasis and perfusion for the tissue, because blood supply and tension-free is especially important in any anastomosis. So it's my conclusion. Understanding the tissue dynamic and management, and to understanding the design of staple instrument to select right staple height for right tissue, and using it option tissue compression were all very important. Of course, patient condition and the surgeon's surgical technique I have just mentioned is also very important, but I didn't highlight today. As we learn about more, we have better surgery and better patient outcome. Thank you for your attention.
According to the arrangement of the committee, we move to the next part, and all the discussion will be open after all talks finish. Next speaker is Professor Fingerham, and he will focus on the leakage of the colorectal surgery. And Professor Fingerham currently is a professor in Gastro and Digestive Surgical Unit of Central Hospital International Policy Branch. And leakage is a major complication of colorectal surgery and also a nightmare of a colorectal surgeon. Today, Professor Fingerham will talk us about the prevention, early detection, and also management of this major complication. Let's welcome Professor Fingerham.
Thank you. Actually, the title that you just announced is not exactly what I have prepared, but it's okay. I'm sure you'll be happy. And I'm very happy that I give this talk just after the one that you've heard. I think it's going to be very complimentary. I'm going to try to go through rapidly, because I only have 15 minutes, 4 aspects of anastomotic leakage. I could talk on anastomotic leakage for a day, but we only have 15 minutes. These 4 are ischemia, some of the mechanical factors, some of the tactical factors that are going to go very complementary to what you've just heard, and then I'll end with some patient factors. I think you have to realize that the blood flow through the colon is tenuous. If you look at this slide and you see the differences in blood flow, or the ease of blood flow, you know that you can see that it ranges from being very poor in the esophagus to being very good in the small intestine, but also going down as you go to the colon and then to the rectum. The consequences are you have to be very careful of the blood supply when you're performing colectomy. And it's very important to respect a certain amount of rules and not to be too close to the mesenteric border when you're peeling off, when you're trimming off the mesenteric. You also want to make sure that your line of division or stapling does not go in the wrong direction. You want to make sure that you have a shorter end on the anti-mesenteric end as compared to the mesenteric side of the colon. There is another problem, vascularization, that I'd like to insist on. You've heard 2 excellent talks by Professor Kim from Seoul. One on right colectomy, the other on the left colectomy today. And it all basically stems from the fact that we have, I can get my arrow to work here, that we have this marginal David Drummond's marginal artery that is a connection between the inferior mesenteric artery system and the superior mesenteric artery system. What you have to remember is that there is a cutoff between the 2 systems, which is known as Griffith's point. Now, Griffith's point comes from a publication many years ago, and Myers in 1976, did a remarkable anatomical study. And what he showed was that the continuity of Drummond's artery, marginal artery, was either faulty or absent in practically half of the cases. So that continuity between the mesenteric arteries, left and right, or inferior and superior, is far from something that's constant. Now, what are the consequences of that? If you have a problem with the inferior mesenteric artery, arteriosclerosis, previous surgery, you have another connection which is formed, and that is the connection that was described many, many years ago in France by Riolot. But what does it mean? It means that you have to be very careful when you're doing an operation, whether it's a right colectomy for something, a tumor on the right angle, the hepatic flexure, or when you are dealing with other problems, like we've heard of today, when you want to look at the problems that are related to left colectomy. Now, sorry, this is a little bit out of order. The two problems are these. You all have heard that there's a difference as far as carcinology, the principles are concerned, between the high tie and the low tie. However, you have to realize that there's also a balance between the high tie and the low tie as concerns the vascularization. If you do a high tie, you're going to cut also the supply coming from the left colic artery. And if your marginal artery is patent, there's no problem. But if your marginal artery is not patent, you do have a problem. So there's a cutoff here.